We're good to go, ma'am.
Hello and welcome in today's nursing webinar session. Myself Shanti, and we are going to talk about the fundamentals about the trauma care. As you all know, trauma is a major global, health burden disease in Indian scenario. And having said so, as an expert panelist, we have Dr. Raghu Garu, who is our HOD Emergency Medicine from Yashoda Hospitals, Malakpet. I welcome you, sir.
Good afternoon. Thank you.
Yes. And as a speaker, we do have Miss Santhiya Ganeshan, who is our senior nurse working in Yashoda Hospitals, Malakpet, in emergency department. Welcome you, Santhiya.
So much, ma'am.
So yes, you can share this slide, and we are going to talk about the as we were discussing about the prevalence and epidemiology of this trauma state. So, sir, my first question to you, as we would like to understand, Santhiya, if you can just share the first slide. Do you agree with the prevalence and statistics of the trauma, as we have seen trauma and acute care as defined by WHO, that every 2 minutes and the deaths every 8 minutes on Indian roads are happening, and it is contributing to 22.8%, which is again 29% for all trauma cases. And major, the alcohol consumptions are more, and rising to TBI again, and 78% are 20 to 44 years of age group. So what is your insight about this?
Yes, madam, because if you take whatever you take, our statistics comparing to the other will be very poor. Comparing to any other thing, we have a very poor data collection. So if you take the last statistics we were done by the AIMS Trauma Center in Delhi, so that was done in 2017 to 18 and published in 2021-22. So according to them, they say 0.5 million people lose their lives according to this study. And they gave the statistics saying that this 49% of the, if you take the 100%,
Yes.
most of these are the craniocerebral injuries, and 25% are the hemorrhage and shocks, and 16% they have accommodated the abdominal trauma,
Yes.
and 3.54%, which is the coronary insufficiency secondary to the trauma. So this, rather than that, I couldn't find the previous guidelines. This is the only guidelines which, the statistics which were mentioned there.
Yes, and that itself is a very, very large factor and contributing to major, health condition.
They have accommodated almost 4,000 patients in this data.
Yes, yes. So let us see what we have in rest of the session. Over to you, Santhiya.
Thank you, ma'am. Hi to all. A very good afternoon to all. I am Santhiya Ganeshan, working as a registered nurse in emergency department, Yashoda Hospital, Malakpet. Here we are discussing about the trauma care and the fundamentals of nursing. So what is trauma? In the sense, we are having a trauma and the major trauma. Trauma in the sense, trauma is a serious injury to the body. The major trauma, it is a series of injury or a combination of multiple injuries, which means one or more fracture that may lead to an polytrauma, that may mean life-saving interventions like an airway obstructions and breathing difficulties, internal or external hemorrhage, etc.
So, sir, as an expert, how would you define trauma from your point of view? Because you're the one who keeps witnessing these cases.
As you have labeled this definition, this works well only.
Yes,
So what way is the same? It's the same life-threatening injury. It suddenly develops when the entire body or the part which has been hit by an object or something.
Yes.
So which can be lead for a minor injury to the major devastating injury. So it can be a chest, head, abdomen, pelvic. So whatever it is, whenever you have an impact, so it can be a life-threatening or a minor injury.
Yes.
Next is the main aim of trauma care. Here is a quick triage. Triaging in the sense, prioritizing the patient according to their condition and the illness, effectively assess, stabilize, and treat the patient with traumatic injuries to prevent the death and disability. It is the main important thing we need to follow it. This involves an rapid assessment, identify the type, which means we need to identify whether it is in what type of wound, like penetrating wound or else in blunt injuries or in trauma, and with the extent of injuries. Next is in stabilization. Here, it is also plays an important role to ensure the airway, breathing, and circulation which we are maintained. Next is in definitive care, providing the necessary medical and surgical interventions to treat the injuries and preventing the secondary injuries. Here, our nurses plays an important role to prevent and secondary injuries by providing and safety measures and facilitating recovery and return to the normal function.
So when we are talking about this main aim of trauma care, sir, do you think the awareness of these aim or trauma guideline is being well spread in the community? Like, are the patients safely they are able to come to our hospitals at within the time period? Sir?
So because if you take our government, if you take the 108, which has been started of late, so they have these trained paramedic who is there inside, who can assess the immediate thing, whatever best he can do. He can do the triage. If requires, he'll be doing an intubation there, then transporting to the respective ED, whichever it is nearby to him. So whatever best he can do, it is. And of late, we are putting all kind of charts wherever it is needed, and we are educating all the common public. And we on the highways, if you take, you have a helpline number
Yes.
where they can access and can reach the ambulances or these things for the benefit of the trauma patients.
So
And the first,
yes.
yeah, and the first thing, if you take the first 10 minutes, what we call the platinum minutes, are important for any patient or any victim who is there. So it is the primordial death which is there. Sometimes it can be preventable and sometimes it cannot be preventable. So first, if you take the trauma care guidelines, platinum 10 minutes makes a major role.
Yes. So chain of survival is being taken care in the nowadays in the current scenario. That's what you meant, sir?
Yeah.
Yes.
The next one is then causes of trauma. There are many causes which leads to a cause trauma, but we are discussing the few common causes which may leads to trauma. The first and foremost is an road traffic accidents and the fall from heights. Fall from height in the sense the patient may get a fall from height which may leads to an polytrauma or a fracture of one or more bones, and the violence and abuse which may leads to an physical abuse, natural disaster, example and earthquake and floods, man-made disasters such as a bomb blast. And the next is clinical manifestations of trauma. There are many clinical manifestations of trauma depending upon the patient traumatic illness. The few common clinical manifestation we are discussing here, that is severe pain, hemorrhage, respiratory issues, fractures, palpitation, shock. Shock in the sense the patient may leads initially to an hypovolemic shock and then neurogenic shock and obstructive shock, confusion, and post-traumatic shock syndrome.
So I'm sure, sir, this causes and clinical manifestations varies as per the severity and case specific.
So again, if you take these symptoms, again, the presentation may vary from patient to patient. Some patient may present only a small laceration. So next, and crush injuries. Next, a fracture you can see. Then the blunt injuries, like the major big five, what we call if you take the head injury, then the chest, then the abdomen, then the long bone, and the pelvic injuries. So I think what we should note is the event which should be taken from the kin and kith or whoever is attending the patient. What is the mode of the injury? So how it happened? Basing on that, you can elicitate the type of injuries the patient can elicit and the extent of the injury the patient can have. It is a high velocity injury or a low velocity injury. And patient ejected from the vehicle. So again, this plays the major role of clinically illustrating when you don't know the history also.
Yes. Yeah, sixth, you can go with the sixth slide. Yeah.
Here comes our primary survey. The nurses, assistants, and the assessment and care, which are led by the nurses with the assistance of assisted by the doctors. And here we are following the simple mnemonics called as an A, B, C, D, and E. And the A stands for airway with C-spine stabilization, and B stands for breathing with ventilation, and C stands for circulation and hemorrhagic control. D stands for disability with GCS monitoring, which is nothing but an Glasgow Coma scale monitoring, and E stands for exposure and hypothermia prevention.
And hypothermia and log roll method also, I think we have to monitor, right? How
Yes, ma'am.
the way of any fast scan also, I think, yes. So,
E-fast
sir,
scan.
again, like when we were discussing, are nurses able to assist the doctor, like I mean, with you all, with surveys when patient arrives in ER, or the bedside practice will enhance their skills?
So of late, when we were interacting the nurses, they were able to have this serial methodological approach, like when they were saying the airway with C-spine immobilization, all the trauma victims. So we don't know whether the cervical spine is intact or not. So these patients, when we are assisting the ambu bag ventilation, there should not be a head tilt and chin lift. We should give only a jaw thrust.
Yes.
So when you are doing again a ventilation, again there should be a proper seal, no flexing with the neck and same. And again, breathing and ventilation. Circulation again plays a major role. Whenever there is a bleeding thing, you should give a direct pressure so that the bleeding doesn't occur, then the hemorrhage gets controlled. And when you take the GCS again, the disability and the GCS monitoring, and one thing again, I mean to specify again, look for the pupils also when you have this D.
Yes.
So GCS monitoring along with the pupils, with the pinpoint, anisocoria, dilated fix. And again, the E parts, exposure, hypothermia. Here always see the event.
Event, yes.
So, I mean to add this one event. How did it happen? Whether he was ejected, what was the mode of injury. Basing on that, we get many clues what we can examine on the patient scene. So if the patient has fallen on the right side, so we can suspect all the right side injuries.
Opposite side. You mean the opposite side?
Yeah, if he has fallen on the right side of the thing, so we can expect the right shoulder, right side of the ribs, then we can expect the liver laceration in the
Yes.
right side of the pelvic, then the femur, like that. So that's how we see the injuries, how this is a event which has happened. So they are learning, they're able to elicit, and they're also part of these trauma team because they also play a major role along with the doctors. The
Yes.
nurses have a major role in the whatever they do.
Second one is in secondary survey. Here we are following an head-to-toe examination, the complete body exposure, and we are going to assess the any laceration or any wounds and etc. We can able to examine over the patient body. Here also we following the simple mnemonics, which is called as an ample. The A stands for an allergic history. We need to ask the patient whether they were having any past allergic reactions to any drugs or else foods. And the M stands for past medications. Whether they are having or taking any past medications for any their comorbidities or etc. Then P stands for past medical and surgical history, whether they are underwent any surgeries for the past. And L stands for the last meal intake. And E stands for even leads to injury, which are nothing but the causes which are leads to an trauma. The next one is an EBP, which means an evidence-based practice trauma pathway and the principles. Here we are discussing the previous times as earlier. We are discussing a brief on that. Airway with C-spine stabilization. Whenever the patient came to ER with a trauma, we have to assume that the C-spine injury. The presence of C-spine injury or we are suspecting any tenderness over the C-spine, first and foremost thing, we need to apply the C collar, which is nothing but the Philadelphia collar to the patient. And we have to check the airway pattern, see whether the patient can able to talk or else they have any obstruction over the airway. We have to see if the patient is able to talk, his airway pattern was completely normal, and we have to go ahead. And if it is compromised, we have to use an head tilt and chin lift method. If the C-spine injury was normal, if the C-spine injury was present, we have to go ahead for an jaw thrust method. In that, the head tilt and chin lift method was contraindicated. And the next one is an oral airway, which is nothing but an oropharyngeal airway, OPA. It improves an airway patterns of the patient, and it also prevents a tongue fall of the patient. And if it is not compromised, we have to go for an definitive airway, which is nothing but an intubation or else an tracheostomy.
So, sir, earlier we did not have these kind of pathways which would guide us, order wise what we are supposed to do. Let's say arrival of the patient, imaging, fastly scan, and all the methodology of assessment. Now, do you think, sir, trauma pathways have improved nurses' productivity because these nurses also have got some evidence-based practice checklist to be followed with, where the documentation, monitoring, timely medications, everything is going right. So what is your take on this, sir?
Yeah,
And
first,
when definitive airway is planned in case of this compromised airway? Yes, sir.
so again, trauma pathway makes this all the nursing staff to not deviate from the thing. So if you come to the systemic order like A, B, C, D, you don't miss anything. So once the A is finished, we come to the B. Once the B is come finished, the C like D. So the systematic order will be followed. So all the patients who may be received in a scoop stretcher bar or
Yes.
the trauma table. So then again, we assume we are immobilizing with the C collar. The C collar is not there. We are placing sandbags, which where the C spine is immobilized.
Yes.
And then the airway is, as she said, the patient is able to talk. We say the patient is airway is patent. So when the patient is attended, we can say that the patient airway is threatened. So we address the airway, then we come to the ventilation. So we basing on the GCS again, low GCS patient, we give a try first. The intubation part is secure. When the AB is secure, then always securing the airway again. If you have this approach, like if the A airway of the plan fails, then we go for the B. The B fails, the C like this. So once if the patient is having a difficult airway, so all these patients, whenever they come, if they have this oral blood, everything, the suctioning will be done. Then the oropharyngeal airway, according to the size, it is placed. So then the oral suctioning is placed, so which is preventing the tongue fall, so which is allowing us to ventilate when there is a ventilation is needed. So when we have a difficulty in putting an endotracheal tube, so when we have then again the uh, front of neck access of the tracheostomy, whatever it is needed, then the plan D, which is the tracheostomy, is so whatever it is needed. So we have the backup of everything, so which is known to our staff also. So they will be planned according to this. So if the A is failed, we have the B. The B is failed, we have the C. The C is failed, we have the D, like in the front of neck access the tracheostomy, whatever is the surgical area.
Yes.
Here comes in breathing and ventilation. There are three main parameters which is to be assessed. And first one is an inspection. In inspection, we need to see any presence of ecchymosis or a flail chest, which is an abnormal chest, and ecchymosis wound or laceration, contusions, anything. And in palpation, we have to palpate and see whether the presence of any rib fractures. And auscultation, we have to auscultate with the presence of bilateral lung sounds and heart sounds, and if any presence of stridor. And effective breathing, we have to deliver the patient with 100% oxygenation support and the needle decompression for the tension pneumothorax. Tension pneumothorax, which is nothing but in presence of air accumulation in the lungs. For that and immediate management, we have to do the needle decompression in the second intercostal space or in mid-clavicular line. Next one is an ICD, intercostal chest tube drainage. This is an indication for a pneumothorax in the hemothorax. This also to be immediately need to be done. This to be done in fifth intercostal space.
So, sir, sometimes when we see nurses doing the bag valve mask, so what should be considered by the nurse when they do this procedure? So sometimes, they do not do in a proper way. So, few points if you would like to tell us.
So if they are on the head end assisting the bag mask,
Yes.
so you see that there is a tight mouth seal.
Yes.
And if needed, always try to put a oropharyngeal airway so that there will be a tight mouth seal, and which will be helpful for doing a suctioning also. And when they are ventilating, see that the valve is openly appropriate, not too much or too slow, so that if you're putting a veins, so it gets filled in a proper way. Or if you're doing an ambu bag, so see that we give only a half of the ambu bag rather than delivering the full bag, so that it will prevent the barotrauma. And if we are suspecting a chest trauma or a COPD patient, we see that we doesn't give so much positive pressure ventilation. And when the patient is tubed, and we see that we doesn't hyperventilate too much. So every 6 to 8 seconds, if we give a breath, that will be enough.
And with the back valve, 8 to 10 or 8 to 12 breaths, right, sir?
So again, if basing on this, if we are assessing the Bain's mass,
Yes.
again it will be different. If we are giving only a assist ventilation, so that's why we give it every 6 to 8 breaths. If you give a ventilation, that will be enough, rather than hyperventilating and doing a barotrauma.
Yes.
Here comes in circulation and the hemorrhage control. First, we are doing the assessment. We need to assess the patient level of consciousness by using the help of GCS scale and capillary refill to check the perfusion level of the patients. The normal capillary refill seconds was 1 to 2 seconds. If it indicates 3 seconds, it indicates an abnormal to the patient. And the pulse, we have to monitor for whether the patient is on tachycardia or else in bradycardia. And the blood pressure, it plays a vital role to monitor and pressure. The patient may landing in hypotension or else in hypertension. We have to manage accordingly. And peripheral pulses, and we need to palpate the pulses in all four extremities, and we need to monitor it. And fluid resuscitation, administer of IV bolus in case of hypotension. We have to secure a large bore IV cannula to prevent the hypotension, and administer of blood and blood products, and give the anticoagulants injection tranexazole.
So, sir, as we are talking about the prevention of or control of hemorrhage, are these prompt action are crucial to prevent hemorrhage, sir, in the trauma scenario?
So again, if you take the CABC, hemorrhage for all the trauma patients major plays a role. So basing on the injuries, basing on the condition, we have to assess the injury impacts. All the patients who are rushed to the ED, whenever you are placing a cannula, send the blood sample as early as possible to get the exact blood group of the patient, so that once the fluid administration has been started, so we see that the blood product is ready for us, the resuscitation part, rather than dumping all the IV fluids, or by knowing the blood group, or if you don't have a blood group, otherwise the next option we have the O negative, which will be the universal donor. But try to secure the cannula as early as possible. Try to get the blood group as early as possible, and we know we administration crystalloids as early as possible, and that will be the choice of fluid administration. So do not give colloids here. Only give crystalloids, and that too will be a normal saline, which will be a fluid of choice. And do not administer too much of IV fluids, so that where blood products will be not having the place to give. And whenever there is a bleeding, open bleeding, apply a tight pressure so that it will be having a hemorrhage control.
Yes.
And the thing is, as she mentioned, the blood products, and if you have Trenexa as early as possible within 3 hours, if you give, that plays a better role than the delayed one.
Okay. Yeah. That's very great point, sir. Yeah.
Next is on prevent disability with GCS monitoring. The rapid neurological assessment to be done. Here comes again our GCS scale. There are 3 vital parameters in the GCS. The E stands for an eye response. The maximum score is 4. And V stands for verbal response. The maximum score was 5. And M stands for the mental status. And this the maximum score was 6. And we need to assess accordingly. And pupillary reaction. Here we are using a mnemonic called PERLA, pupil equally round and reactive to light and accommodation. Here we need to assess the unequal pupils, which is called as an anisocoria. The normal pupillary size is 2 to 3 mm. Next is an exposure with hypothermia prevention. Here comes in full body exposure. We need to expose and examine the patient total body. We need to assess the presence of any ecchymosis, contusions, abrasions, lacerations, and any misplaced bony deformities and flail cyst. All these things need to be examined. And once after examined, we need to completely cover the patient with blankets, and we also need to provide an warmer and bed sheets. And glycemic management, once the patient occurred as trauma, the patient may suddenly leads to an hypoglycemic or else an hypoglycemic. If in case the patient land up in hyperglycemic, we have to give an 20% dextrose, which is 100 ml. And if the presence of hyperglycemic, we have to treat the patient accordingly as per a physician order.
So, sir, and when we are talking about this hypothermia prevention, so many of us we get to see sometimes we are so busy that we do not check on this hypothermia condition. And is it a bad indicator for trauma patients or recovery or outcome?
Yeah,
It enhances that.
hypothermia again is a bad indicator of thing. So we have in the trauma triad of death we call. So
Yes.
in that hypothermia is one, acidosis is one, and coagulopathy is one.
Yes.
So whenever we are undressing the patient to see any missed injuries, so simultaneously we have to cover as early as possible to prevent a hypothermia. So these hypothermia again can be prevented by infusing warm salines,
Yes.
then providing blankets. Then if you have a ED with a warmer, we can do this. And when you're giving a blood transfusion also, we can have this blood products transfused, which can be preventing the hypothermia. So that also can be taken into mind. Again, these hypothermia, what it does, it further causes a coagulopathy, and where there will be a decreased perfusion, which increases the mortality. So that's why hypothermia has to be addressed
The
in the
action has to be
ED
immediately
as
addressed.
early as possible.
Possible. Yes.
And these ET, we should not make the patients into hypothermia. So when we try to examine the patient, we undress him. So we forget to again dress him properly.
So I think
So
when these patients are received in ED and maybe we see a lot of injuries, pool of bloods and all, and then we don't see housekeeping staff or nurses giving them the blanket or bedsheet because they are consider about their things to be soiled and all. But I think the warmer or the blankets, warm
blanket
blankets will be helpful.
major paper, and we have the newer thing when you are giving these blood transfusions, you have blood transfusion warmer also, so
Yes,
which can be prevented this warmer.
yes,
And one more point I want to add is, so GCS to see it will be taking a long time.
yes,
So the simple score will be a AVPU score. See,
yes,
the patient is alert, and V stands for verbal response,
yes,
P for pain,
yes,
and U for unresponse.
yes, yes. AVPU, yes,
AVPU.
yes. And it is there in our trauma pathway sheet also.
Yeah,
So
clearly.
we'll take the corrections.
In exposure, here comes an EFAST, which is an extended focused assessment in sonography for trauma. Here we need to assess for any pericardial fluid accumulation and peritoneal fluid accumulation and the lung slides. Next is our nursing fundamental for trauma care includes, it is an important role and we need to monitor all those things as early as possible. And first is an IV access. We have to secure a large bore IV cannula, and as soon as possible we have to introduce and pain analgesics to the patients and cardiopulmonary resuscitation. Assist in ET tube intubation and investigation CT scans. Blood transfusion and control of bleeding. Here comes in massive blood transfusion. If the patient have an excessive bleeding, we as per doctor's advice, we have to go for a massive blood transfusion, which is on 1:1:1 ratio, 1 pin PRBC and 1 FFP and 1 platelets, and limb immobilization. Here we are having on many immobilizers like knee immobilizer, ankle immobilizer, and pelvic immobilizer, and we have using of splints and casts, and administration of oxygen, fluid resuscitation in the case of shock, which is an hypovolemic shock, and counseling and support to the family. Here comes an important role to the nurses, which is an we have to give the psychological support to the patient as well as the family. Next is on hemodynamic monitoring. The nurses need to monitor the blood pressure. By that, we can already discussed. And heart rate and rhythm, we have to continuously monitor the patient heart rate as well as the rhythm to prevent any cardiac arrest and etc. So next is on blood saturation to prevent any hypoxia. Lactate levels to prevent any sepsis. The patient may land in sepsis in upcoming days, and IV intake and output to prevent a hypovolemic shock.
So, sir, as Santhya is rightly mentioning, are these nursing interventions being properly done, monitored, or any gap do you get to see which should be addressed in this
These
large
are
forum?
done, so as soon as you see any polytrauma, to large bore IV access has to be
Yes.
accessed as early as possible, and pain should be addressed for all patients, because we see some patients pain is not addressed they will be doing this immobilization without giving any analgesic.
Analgesic.
The basic analgesic is not doing, at least if you have an luxury of opioid, use that opioid so that patient is calmed down a lot.
Yes.
And that can be again used in a ET. So always when you are shifting these patients to the scans, so if you have a borderline GCS, try to secure an airway, then only shift for the CT scans, so that the patient may not be having an aspiration, or we may not have any chaos in the CT scan rooms. And as she has mentioned, getting a blood group as early as possible and following the MAT protocol that will be helpful for the patients, like the MTP 1:1:1.
Yes.
And the limb mobilization, as she mentioned, we have different immobilizations so this will reduce the pain and which will stabilize the patient limb, which is fractured.
Yes.
And so these patients will be deprived of oxygen because of the blood loss. So we have to administration the O2 whenever it is required. And so better to have a damage control resuscitation targeting the blood pressure around 90 to 100, not achieving more than, so that even if the bleeding which is there, which will get controlled. So the
Yes.
damage control resuscitation should be taken into this, which plays a major role. And lastly, she has all these patients who come with these accidents, the family kin and kith will be in the mourns. So the counseling support and the family should be given. So that will help the family burden to at least to take care of these things.
Yes. Yes. Yes, you can come to the 14th. Yes, 14th, 15th. Yeah.
Dressing and bandaging. There are different types of dressing which we are commonly following. And Vaseline dressing and the hydrocolloid dressing, which were commonly used to treat the burns patients, and the gauze dressing, which we are most commonly used for all those trauma patients. Dressing trolley should be consist of all the items, which is the nursing responsibility to arrange all the wanted articles that should be ready with all the times. And nurses should also know the different types of bandaging techniques. Wound debridement and the management. Here comes in penetrating wounds, which is in a certain foreign body or in sharp material which comes in contact with the skin and deeper into our body tissues, and blunt injuries such as in contusion, abrasions, and lacerations, and burns, which is in flames or scalp burns and electrical burns. Do saline motion dressing to remove the excess or remove the foreign body carefully. Use of splints, tractions, cast, and POP should be known by nurses and doctors.
So as Raghu sir has already discussed that the availability of these things should be there within the proximity, and so that no debridement and every wound can be managed along with the dressing technique. I think, sir, yes, you will also agree.
So one thing I want to add is always check for these, because all these will be a contaminated wounds. Wounds may be of sharp objects. So always try to inquire from the patient when he is tetanized. So always give the TT injection. And if you have a crushed wound, a contaminated wound, it is better if you have the facility of tetanus immunoglobulin. So basing on the age, so we can give 250 mg or 500 mg. If it is available, so it is better to give tetanus toxoid and tetanus immunoglobulin, the TEDGLO.
As to said, not to forget the infection prevention aspects. Here also comes in the nurses plays a vital role and infection prevention aspects. Follow the aseptic techniques. While we are dealing with the patient, we have to follow the aseptic techniques and sterile dressings. Here comes an TT prophylaxis, which should be given as soon as or immediate to the patient, and prophylactic antibiotics to prevent the upcoming sepsis.
You can further share the slides, and we are just coming to the end. And I think, sir, you will also agree that we have some specific consideration of ages like pediatric, geriatric, and pregnant patients as per trauma impact. And we need to, assess them properly, like risk of injury and child-friendly communication, because they are the, different age group of child who comes to the ER. Higher risk of fractures, which is involved with the geriatric age group. And maternal fetal care also to be taken care, and we need to involve the pediatricians and gynec in this condition. Yes.
So yes, because all these you have mentioned, they come in the special population.
Yes. Yes.
Yeah. children as with the major thing is the adult age where they have the brittle bones. So the fractures will be more for them. So that has to be taken part and which is delayed in their recoveries.
Yes.
And if you take the maternal, both are involved, the child and the mother.
Yes.
So that also has to be taken. The perimortem cesarean section has to be taken into consideration in this part.
Yes. So as we have already told about our trauma pathway, which is again integrated evidence-based practice, we have beautiful guidelines here. And yeah, Santhiya, you can share the slide. Yeah, this is again burns and pain assessment sheet as we have Wong Baker and VAS score chart guideline. I think everybody follows this kind of charts. And now here we have come to the end of the session, which is again our conclusion. I think as we were discussing throughout the half an hour session, the role of nurses in trauma care is very vital because again, yes, they should also know rapid assessment and triage methodology. They should also be trained in BLS and advanced cardiac life support, coordinate with a multidisciplinary team, which consists of all the, paramedics, right from doctor, physicians, surgeons, everybody, and which will enhance their skill to prepare themselves for the large scale trauma events. I think, sir, you will also agree with this, and with this, we end the session.
So 1 minute, I want to just add it.
Please, sir.
So because we have this primordial modes of death. The first one will be the platinum minutes, where you have the sudden deaths because of the major neurovascular thing, which occur in the first 10 minutes.
Yes, sir.
So second is the golden hour. So where we have to take care the things as early as possible. And the third peak of death will be which will be occur in the days and sepsis, because this will be secondary to the sepsis and mods because of the injury.
Yes. So what was your second point, sir? Would you please repeat?
The golden hour, the first,
yes, golden hour. Yes, sir.
Yeah.
Yes. Yeah. So here the end of the session comes, and thank you, sir, for having you with us, and thank you, Santhiya. It was a beautiful session, and we like to have many more sessions, such kind, and we end the session.
Yeah, thank you. That's a good, nice.
Thank you.
Thank you.
Thank you, Santhiya.